Welcome. I am Terry Tropin, and today I'll be discussing the 2023 update for CPT's Evaluation and Management Codes, specifically changes to specific sections of codes. Let me start with some information about myself. I have a master's in Healthcare Administration Informatics from the University of Maryland Global Campus and have RHIA and CCSP certifications. I'm also an HEMA-approved ICD-10 trainer. I taught health information technology at Montgomery College in Maryland for over 20 years. I've also written books on coding. These books are study guides that summarize the coding guidelines. My books include one on E&M coding, one on ICD-10-CM, and one on ICD-10-PCS. These two books, I have 2022 versions, but I also have 2023 versions up on Amazon. The E&M book is up on Amazon for 2022, but the 2023 version won't be up until later this fall. So here's an overview of what I'm going to talk about. If you would like to purchase a copy of the slides for this video, give me a thanks of $5 or more and comment with your email or send a note to terry.tropin@gmail.com. I will send a PDF of the slides. Click the thanks button under the video. So here's my overview. This video covers changes to inpatient and observation services, consultations, emergency department, nursing facilities, home or residence, and prolonged services. Let's start with the changes to inpatient observation care codes. This is big. In 2022, hospital inpatient care codes were 99221, 99233. Observation care codes were 99234, 99236, separate sections. In 2023, these were combined. Both inpatient care and observation care services are reported using the same set of codes. The separate codes for observation care have been deleted. And also the discharge codes for inpatient observation were combined into 99238, 99239. So these are now one set of codes instead of two separate ones. Okay, so here are the changes, and the part that is underlined is what is new. Patient admitted to the hospital as an inpatient or observation status in the course of an encounter at another site of service, e.g. hospital, emergency department, office, nursing facility. The services in the initial site may be separately reported. So a patient is seen in an outpatient service and then moved into an inpatient, moved into an inpatient or observation service. These can be reported separately. Previously, if a patient was seen in an outpatient or other environment and then admitted the same day as an inpatient or observation status, the guidelines said all of those services performed on that date are rolled into one code, the admission code. So this is really different. The guidelines also state that the outpatient or emergency services can be reported separately using a modifier 25. So also for inpatient observation services, a patient transferred from observation to inpatient is reported using one code. So this makes sense since these codes are now combined. So this is inpatient and or observation services performed on the same stay, during the same stay. So observation, the same day admission and discharge for inpatient observation. So the requirements have been tightened up a little bit. So what it says is you need at least 2 encounters in order to use these codes. 1 encounter for the admission, another encounter for the discharge, both on the same date. If this isn't done, if a patient is seen for admission and then there's not a discharge encounter, use codes 99221, 99222, 99223, hospital inpatient or observation care initial visit. So you use only the initial visit code instead of the admit and discharge codes. Okay, so changes were also made to consultation code. The definition of a consultation was changed. They added other qualified healthcare professionals. You can see that in the first bullet and in the second large bullet. And also, they changed what the definition of a consultation is. It says recommend care for a specific condition or problem, but they deleted wording to determine whether to accept responsibility for ongoing management of the patient's entire care or for the care of a specific problem or condition. That was deleted for 2023. Okay, observation consultants. Another change concerns who can receive a consultation. The list has been revised for 2023. You can see underlined observation level patients was added. Also in the second part here, the longer bottom two bullets, when a patient has not received any face-to-face professional services from the physician or other qualified healthcare professional, or another physician or other qualified healthcare professional of the exact same specialty and subspecialty belongs to the same group practice during the stay. Okay, so that means that this patient's never seen anybody, never seen this physician for, or anybody from the same practice, same specialty, same subspecialty, they can report a consultation. Now, if it is same practice and the exact same specialty or subspecialty, then they can't do a consultation. Also added to this was services provided by an advanced practice nurse and physician assistants working with physicians. These people can report consultation. These providers are considered as working in the exact same specialty and subspecialty as the physician. So who can initiate a consultation? Note the providers that are crossed out for 2023. Physician assistant, nurse practitioner, doctor of chiropractic, physical therapist, occupational therapist, speech language pathologist, psychologist. Those are crossed out on who can initiate a consultation. They had social worker remains, but they added the descriptive phrase non-clinical social worker. They also still included or educator, lawyer, or insurance company. So other qualified healthcare professionals, the examples were deleted. Okay, so here's a scenario, a specific scenario. So say Dr. A performs a consultation in anticipation of or related to admission by another physician or other qualified healthcare professional to inpatient or observation care. So Dr. A performs a consultation, another physician or provider is going to admit the patient. After the admission of the patient, Dr. A performs another E&M service. So report the consultant's inpatient encounter with subsequent care codes 98231, 32, and 33. This instruction applies to a consultation occurring on the date of the admission or a date previous to the admission. And that initial consultation can be reported with the initial, with the appropriate code. But the second time Dr. A sees this patient, when they're now an inpatient, you do subsequent care codes. Okay, here's another scenario for follow-up visits. This is when a second consultation takes place after the first one. The second consultation occurs in the provider's office or other outpatient area. Remember, the first scenario was outpatient, patient then admitted. This is follow-up visit in office or other outpatient. So this is all outpatient services, the first one and the second one. The consultation can be initiated by either the Dr. A or by the patient. So you're going to use the established patient codes in the office, home, or residence. So this is an established patient, and then you use the code from wherever the appropriate site of service is. Okay, so let's go forward to the emergency room services. So the new guidelines state for procedures or services identified by a CPT code that may be separately reported the same date, use the appropriate CPT code. So you can do an emergency department service, E&M service, and then any other service that's provided on the same date. You can report that code separately. It says use the appropriate modifiers to report separately identifiable E&M services and the extent of the services provided in a surgical package. It's just decision for surgery. If a patient is seen in the emergency department for the convenience of the physician or other qualified healthcare professional, use office or other outpatient services. So just because they're in an emergency department doesn't mean it's an emergency. So if the patient calls the doctor and says, I got this problem, and the physician says, I'll meet you in the emergency room because that's more convenient for him or her, but it's not really under the emergency department services, you should use office or other outpatient services codes, not emergency room ones. Okay, so here's an interesting change for critical care and emergency services. Critical care and emergency department services may both be reported on the same day when, after completion of the emergency department service, the condition of the patient changes and critical care services are provided. So a patient comes to the emergency room, services are provided, and then the patient becomes critical. So you can report the emergency room service and the critical care services, even if provided on the same date. Changes were also made to the guidelines for nursing facility codes. The guidelines were revised. These services are performed by the principal physician and or other qualified healthcare professionals overseeing the care of the patient in the facilities. The principal physician is sometimes referred to as the admitting physician and is the physician who oversees the patient care as opposed to other physicians or other qualified healthcare professionals who may be furnishing specialty care. So you have the admitting or principal physician, and then you have others who provide other cares. So that these codes are reported for those. These services are also performed by physicians or other qualified healthcare professionals in the role of a specialist. So you have the principal physician or the admitting physician, and then you have other specialists, other physicians, specialists performing a consultation, someone performing concurrent care, and you may use modifiers to identify the role of the specific individual. So this is interesting. The nursing facility care includes skilled nursing facility and nursing facility, but all of those services are reported using the same set of codes. So how do you know which kind of service it is? Well, the place of service codes should be reported to identify the type of facility and care where the services are performed. The place of service codes indicate the type. For example, 31 indicates skilled nursing facility. Place of service 32 indicates nursing facilities. These codes are listed in the front of your CPT book. So this is how you differentiate between the types of service. So nursing facility, they've made some changes to psychiatric residential treatment center. In 2022, there's wording of defining the center as a facility or distinct part of a facility for psychiatric care, which provides 24-hour therapeutically planned and professionally staffed group living and learning environment. So that definition is gone. Added, however, is the phrase also used for immediate care facility for individuals with intellectual disabilities. It is interesting that a separate element of medical decision-making was created for nursing facility care. This element is part of the number and complexity of problems addressed at the encounter in medical decision-making. Note that this is used for high-level medical decision-making only. So this is what the new type is. Multiple morbidities requiring intensive management. a set of conditions, syndromes, or functional impairments that are likely to require frequent medication changes or other treatments changes and or reevaluations. The patient is at significant risk of worsening medical, including behavioral status, and risk for readmission to a hospital. The definitions and requirements related to amount and complexity of data to be reviewed and analyzed, and the risk of complications and morbidity are unchanged. So those are the same used for all the other codes. So the only change is that there's this additional type of MDM for problems, complexity of problems. Okay, nursing facility providers. Sometimes more than one provider is involved in performing the services. Medical necessary assessments provided prior to the initial comprehensive nursing facility service are reported using subsequent nursing facility care codes, 307, 308, 309, 310. So there's assessments and there's consultations. So consultations provided at admission to nursing facility are reported using the initial nursing facility codes or inpatient or observation consultation codes. This applies whether or not the principal care professional has completed the initial comprehensive services. So this is completely separate from that primary or admitting physician services. So a consultant admits a patient can use initial nursing facility or inpatient or observation care consultations as appropriate. So initial nursing care facility codes 99304, 05, and 06 may be used once per admission for each physician or other qualified healthcare professional, regardless of the length of stay. Sometimes the patient can be in a nursing facility for a very long time, but they're only admitted once. Initial nursing facility care only once per physician. If you have that consultant who's doing an initial services care, and then again that primary admitting physician doing the the more extensive assessment, each of those can do the initial care codes, but one physician can only do it once. Okay, who provides the service for initial facility care? The guidelines state for skilled nursing facility care, the initial comprehensive visit must be performed by a physician. The principal physician or other provider may work with others who may or not always be in the same group, but the principal physician or provider is overseeing the overall care. So you have someone overseeing, and then you may have other people working with them. For other nursing facility care, the initial comprehensive visit may be performed by a qualified healthcare professionals if allowed by state law or regulation. So there's a real difference. Even though the skilled nursing facility and other nursing facility care are both reported using the same codes, there are differences between who can do the skilled nursing facility and who can do the other nursing facility care. Sometimes a patient is moved between skilled nursing facility and nursing facility care. The guidelines state that this is not a new stay in the new facility, so initial services were not re-reported after the move. So again, since the nursing facility care and skilled nursing facility care are done with the same codes, you can't have two initial, even if care codes, even if they move between nursing facility and skilled nursing facility. Okay, so initial service. Report an initial service for a new provider who sees the patient for the first time during the stay. Remember, we said each physician can do an initial service one time, but you could have multiple providers reporting the initial service. So a new provider who sees the patient for the first time during the stay. This includes a provider who has not performed any face-to-face professional services and a provider in the same group, exact same specialty and subspecialty as a provider who has provided services during the stay. When advanced practice nurses or physician assistants are working with physicians, they are considered as working in the exact same specialty and subspecialty as the physician. An initial service may also be reported to the physician as a new patient, as defined in the evaluation and management services. Okay, new are established, 99304, 99306. When the patient is admitted to the nursing facility in the course of an encounter in another site, in the emergency department, for example, the services, the initial site can be reported separately. So again, before this was kind of all rolled into one, and now it is not. In 2022, everything associated with the admission that happened on the day of the admission was rolled into one. That wording was crossed out. The added wording states that separate services can be reported separately with a modifier 25. So this is also a significant change. So here's a scenario. Provider performs services in a different site that admits the patient to nursing facility care as a consultation on the same date. The consultant reports the subsequent nursing facility care codes for the second service. So this is when the consultant is not being the primary or admitting physician. They're using the subsequent nursing care. So nursing care discharge services. Changes were also made to these codes. What's new is the requirement that the encounter be face-to-face, that the encounter may be on a date prior to the date the patient actually leaves the facility. So they can do a discharge and say, okay, it's not 10 o'clock in the evening, we'll release you at 8 o'clock tomorrow morning. If that's okay to report it that way, even though it's not the same date. Okay, the next thing we'll discuss is domiciliary, rest home, or custodial care services. These codes, 99324 and 99340, have been deleted for 2023. A note refers you to codes in a new section, home or residential services. Okay, so these have all been deleted. Oversight services for these codes have also been deleted. And a note here refers you to the principal care management codes. So for the first set of codes, it's sending you to the home or resident services codes. These are new codes. For the second set of codes for the oversight, it's sending you to principal care management codes. Okay, so the home services codes are now called the home or resident services, 99341, 99345. So the following codes are used to report evaluation and management services in a home or resident, and it defines what is a home. This is the same as in 2022. Added to this are these codes are also used when the residence is an assisted living facility, group home that is not licensed as an intermediate care facility for individuals with intellectual disabilities. Custodial care facilities are residential substance abuse treatment facilities. Okay. When selecting a code level using time, do not count any travel time. So the physician's time to the home or residence, that's not part of the time that can be reported. Okay, so let's look at prolonged services. Prolonged services codes 99354 and 56 have been deleted. A note tells you that you should use 99417 instead. Prolonged services 99356 and 357 have also been deleted, and a note tells you to use 993X0 for that. Now, I know there's not a 993X0 code in your book. This just means that the number has not been assigned, so they're going to use kind of a dummy number, 993X0, for this. It will be there by the time the code book comes out. Okay, so let's look at 99417. This is an add-on code used only with the highest level of time in a group of codes. So for codes, so 99417, use only when the code's been selected using time alone and the highest level code service has been exceeded by 15 minutes. Remember that the codes now have specific time that you can use. So there's a group of codes and the highest code is used. So for codes 99202 and 99205, new patient office services, this code can only be used for the time for 99205 is reached. So you can't use it with 99202 and the other lower codes in this section. So 99205 is 75 minutes. You add the 15 minutes prolonged services, 90 minutes. Okay. And note that if other services are provided, that time for doing those other services doesn't count towards 99417. You must have 15 minutes and don't report it if there's any time less than 15 minutes. Okay, so that's 99417. For 993X0 is used only when the code's been selected using time alone, again, and only when the time required to report the highest level of service in a section is exceeded by 15 minutes. This code is used for prolonged services in inpatient observation or nursing facility section for setting, with or without direct patient contact. Note that the previous one, 9417, is office or other outpatient services, also with or without direct patient contact. This one is with or without patient contact, inpatient observation nursing facility. So that's the difference between these two codes. Again, time performing separately reported services other than the primary E&M service and prolonged E&M service is not counted. Can't count. Again, can't do it twice. So for example, 99234, 99236 is the section for hospital inpatient or observation care. So this prolonged services code can only be used if the time for 99236 is reached. That's 85 minutes plus 15 minutes prolonged. That equals 100 minutes. So it has to be 100 minutes or more in order to use this code. Okay, what if they're not on the same date? 99358 and 59 may be reported for prolonged services in relation to any other evaluation and management service on a date other than the face-to-face service, whether or not time was used to select the level of the E&M service. Now you saw in the last two prolonged services codes we talked about, it had to be time was the factor in selecting the code, okay? This is whether or not and on a different day. So that's the difference between these codes. Codes 99358 and 99359 may be reported for services such as extensive record review related to a previous E&M service on a previous date, or a service coming up. Services related that has occurred or will occur. So if they want to review extensive records, test results afterwards, that can be reported this way. If they want to review a record before seeing the patient, these codes can be used. Okay, prolonged clinical staff. Change has also been made to these codes. Codes 99415, 99416 may be reported for no more than 2 simultaneous patients, and the time reported is the time devoted only to a single patient. So again, if you see patients and it overlaps, you can only do the time specific to patient A, specific to patient B, not combine them. That might be hard to differentiate if you're going back and forth, but those are what the guidelines state. So a new note was added under 99416. The starting point, this is clinical staff services prolonged, remember. The starting point for 99415 is 30 minutes beyond the typical clinical staff time for ongoing assessment of the patient during the office visit. Okay, so it's 30 minutes. And the previous ones were other providers, 15 minutes. This is for clinical staff, 30 minutes. There's also in your book, there's a reporting prolonged clinical staff time table, and this has been revised. This is actually really good. The table now lists the typical clinical staff times for specific office or outpatient codes and the range of time for each code and when you can start using the prolonged services codes. For example, 99204, typical clinical time is 41 minutes. Report 99415 for 71 to 15 minutes. So that's 30 minutes. You report 99416 for 116 minutes or more. So it gives you exact time. It's much easier. You don't have to do the math in your head. Okay, that completes this video. If you have questions or comments, please feel free to contact me. For more information, see the link to the complete document, which is posted in the video description. Also, see Part 1 for E&M changes for guidelines, which is now posted. See Part 2 for changes to medical decision making, which is also posted. If you would like to purchase a copy of the slides for this video, give me a thanks of $5 or more and comment with your email or send to my email address, which is here. My books are available on Amazon. As I said, the 2023 for CM and PCS, as well as the 2022 are on Amazon already. The Evaluation and Management Coding book is up for 2022. I should have the 2023 one up this fall. Thank you very much for listening. I hope this was helpful. Thank you.